Hi, I'm Rob Seltzer, and welcome to the Aortic Hope Week in Review, where we take a look at all the things that we've posted on our website, aortichope.org. You can go there yourself and take a longer read of the different things that we will talk about today. Before I get started, I would like to take a moment and thank our sponsors who help us provide this information to you and many other things. First, we have Cook Medical, where they innovate and manufacture quality medical devices to improve lives. Their focus is on bringing compelling products to market and keeping existing ones relevant. They're headquartered in Bloomington, Indiana, and global manufacturing facilities. They aim to increase their impact worldwide. Also, we would like to thank Edward Life Sciences, which is a global leader of patient-focused medical innovations for structural heart disease and critical care monitoring. At Edward Life Sciences, they listen when patients talk. Why? Because patients provide them with information about their experience, which can help them improve their products. Their stories inspire them to continue to fight on their behalf, and they can provide comfort and support to each other when they help us connect. So if you'd like to learn more about Everett Life Sciences, their resources or patients, you can look that on our website, and there is a click through to visit them. So once again, we want to thank both Cook Medical and Edward Life Sciences for their support, Aortic Hope. Here we go. And here we are. This is the Aortic Hope website. So every time you come on, this is our home page. You do want to take a look at this before we get into the week in review. This is where you will find on our website the free downloads and order points for our patient guides for those with aortic disease. Also, we have the guide for those with aortic dissection here. We have one in Spanish here. You can order them for yourself. You can download. You can get a hard copy, one per household, or if you're a professional, physicians, hospitals, you may order bulk for your facilities as well. So it's also available on YouTube where you can look at it there and have it read to you as well. So this is a very important part of our project with Aortic Hope and what we do and the services that we provide. Also, do not forget, besides the articles that we put up here, here's where our events calendar is. So you do want to make sure that you can, if you want to see what's happening coming up, here we go. Here are all the events for March that have been posted, the support groups, the things like this. We can regroup view and other events that happen Aortic Hope. So you can check that out and you can click right through and see where those are. So let's move on and take a look at what's happening last week. Well, let's start with Monday. It was Medical Monday. And we talked about TAVRs. Everybody's probably seen that in our chat rooms and our threads on Facebook and on Instagram about the transcatheter aortic valve replacement. So what is this? Well, it's also called a TAVI, a transcatheter aortic valve implantation. It's a way to replace a valve in your heart with a minimally invasive procedure. And when you need to do that because you have what's called aortic stenosis, which is where the aortic valve becomes narrowed and restricts blood flow from the heart to the body. So instead of having open heart surgery, which many of us have already had, they can do this transcatheter method, which sends a valve up through a catheter, which is a long tube, and they usually insert it through your groin at the top of the femoral artery, and they run it up into your heart, and then do all of this without having to do an open chest incision, which is a lot easier to recover from. It only takes a day or two in the hospital afterwards. And let's take a look here at what it looks like. So here is your heart, and coming up here, see through the artery, the return back to this is the left side of your heart. We have the left ventricle, And so here they're coming up the artery, the aorta, I'm sorry, into this, which is where the blood leaves. And so they bring this catheter in. It's inside here. They put it, and then they remove the old valve and put in the new one. So see, we got step one comes up, step two, they put it in place, and step three, they expand it, and you have a new valve. It's really, that was a very non-medical description because I am not a doctor and I will not give you medical advice, but there was my little impression of what's really going on. So it's a lot easier. I've had not TAVRs, but I've had TVARs where they have placed a stent graft here, not in my heart, but in my aorta, and that was done trans catheter as well, but endovascular. Okay, so it didn't go up the aorta here, and it did, and similar, very similar process, but just with a different name. That I did after my open heart surgery, so we've done all that too. Now, I mentioned aortic stenosis. So what is aortic stenosis? Because this is when you have to have your valve replaced. It occurs when the aortic valve becomes thickened or calcified and does not open fully, which then restricts blood flow, which is a problem. Over time, this forces the heart to work harder, can lead to shortness of breath, chest pain, dizziness, fainting, fatigue, or heart failure. Severe symptomatic aortic stenosis has a high mortality rate if left untreated. So who can be a candidate for this type of surgery? But let's take a look at this real fast. There we go, a little close up. So there is the valve that we were talking about again, right? The aortic valve. This is the left side, the ventricle, and this is where we pump the blood out of the heart. So this is a very, very important spot. Okay, I didn't mention that before. And then sends the blood down through the aorta to all our other arteries in our body. So that's the way your valve is supposed to be when it's closed. And here it is when it's fully opened. When you have stenosis and is calcified or hardened, it doesn't close all the way. So we get blood leakage back into the ventricle. And when it doesn't open all the way either, which makes your heart have to push even harder to force as much blood as it can out of your ventricle into your aorta. And that can cause all those other things that we just mentioned a minute ago. So who can get this? Well, originally it was approved for patients that were considered high risk, high surgical risk, but now they have more research and they've gotten better at this type of surgery. So it's now been approved for high risk, intermediate risk, and even some low risk patients so that they do not, they can get it earlier. They don't have to wait until their valve is totally bad. You can possibly have it done earlier. And then some patients that have a prior bioprosthetic valve failure. So they've already had a valve replacement, but some of those do not last forever, right? Typically, not the mechanical ones, but the tissue-based valves do not have a full lifetime. So they often have to be replaced 10, 15 years down the road. So a team made up of your cardiologist and a cardiothoracic surgeon. They evaluate your candidacy. They look at you, your age, how healthy you are, your anatomy, if you have comorbidities, like how's your blood pressure, do you have diabetes, all these different things, and what your risk score is, because that's how physicians work when they do surgery. People often ask in our groups and online about, why can't I just have my surgery now? Why do they say I need to wait? Why can't I do it? Because they come up with a risk score. It's all risk assessment. And if having the surgery now is more risky, higher risk of harm or death than leaving you alone, then they won't really want to do the surgery. But if leaving you alone and not fixing something is a higher risk of harm or death, then they will go ahead and really seriously consider the surgery. Okay, so it's really about risk assessment, and that's what they build a risk score with. Why do we want to have TAVR instead of an open surgery? Well, those of you that had open heart surgery probably already know. It's shorter hospital stays, faster recovery time, it's less invasive, survival rates are very good, and you will have improvement of your symptoms. And like any other surgery, there's always some risk involved. So it can be, anytime, and this is pretty much for every surgery, so don't let this necessarily scare you. Stroke, bleeding, vascular complications, need for permanent pacemakers, and a paravalvular leak, which means the new valve could leak. So that's why they're very careful and do these risk assessments before they say, okay, let's go and do this surgery. So just side by side here. So take a look at the difference. TAVR incision is a catheter that's inserted through your femoral artery up into the aorta, into your heart. Surgical aortic valve replacement is a sternotomy. Sternotomy, cut open your chest, open it up, and go directly into the heart. Recovery on a TAVR, days to weeks. Surgical aortic valve replacement, 6 to 12 weeks. Anesthesia, they can often do it conscious sedation, which is where they put you in a semi-conscious state. They don't totally put you under, so you feel no pain and you are very relaxed, but you don't have any of the problems that can be associated with full anesthesia. Surgical AVR does require general anesthesia. So they are both best. The TAVR is best for many, many different risk levels. Surgical AVR is best for younger patients or certain anatomies. There you go. And the outcomes have all been very good. They done different types of trials, a partner trial, a placement of aortic transcatheter valves, core value evolute trials, low risk randomized trials. So it's really been proven, and that long-term durability data, 10 plus years, continues to evolve and is encouraging. So considerations you might want to take into account. There's lifelong follow-up with cardiology. It's essential. You will always be seeing your cardiologist. Antiplatelet therapy is typically required post-procedure. So what is that? Those are blood thinners, especially if you have a mechanical valve. You will have to probably go on a Coumadin therapy, which is a little bit more difficult. It takes a lot of attention on your part and regular visits to a doctor. And also valve durability, there's with the tissue valves and future intervention planning that should be discussed as well. How long is it going to last? What else are we going to have to do? Okay, so you do want to know what's going on. Stenosis is often underdiagnosed. If you or a loved one experience unexplained shortness of breath, chest pain, or fainting, especially if you're older, evaluation with electrocardiography is critical. Echocardiography, excuse me. Early diagnosis is an appropriate referral to a structural heart team can be life-saving. And as you see this article, these are all, backed up by professional references and such. We don't just, as we're volunteers, I'm going to say I'm not a doctor, we don't just write these posts with out any backing, so to speak. And I think this one, let me make you dizzy, take you up to the top here. And Molly did this one, so you see, that's very, very important. Okay, let's move on to Topic Tuesday, and I think it's going to be a little bit similar. Yep, an alternative to redo surgery, valve-in-valve TAVR. So we talked a minute ago about what happens if the valve fails. So do I have to go through this whole thing again? Do they take it out, put it in? Am I going to have a sternotomy this time and have to be opened up? Well, they now have come up with what they call valve-in-valve TAVR. And this has been produced by our medical student, Kenyon Azahiri. He wrote this article for us. Thank you, Kenyon. So this valve repair or replacement surgery is a common type of cardiac operation. So if you have a valve and it has failed for whatever reason, the bioprosthetic valves, those are the tissue valves, the bovine, okay, are not permanent. With these, they do degenerate and they do need to be replaced. So typically, as I just said, it involves another major surgery to have that replaced. A new option that may be available is called valve-in-valve transcatheter aortic valve replacement. So it's still a TAVR, but they're going to put the new valve into the old valve. So rather than invasive procedure, a TAVR approach allows the cardiologist, the interventional cardiologist, and surgeons to work together to send a new valve to the heart using a flexible tube, the catheter, as we mentioned, through your vessels, most often through a small incision in the leg. So it's very much the same as the TAVR. That's why it's called that. And it's placed directly into the existing tissue valve. So let's just take a look at that. You can read all of this. Let me go back up here. So as you see, they are then taking the new valve and replacing it into the old valve. So it goes in and the old valve becomes the anchor, and then the new valve goes inside and replaces the function of the old valve. So it's still surgery, but it's not as major as the other surgeries used to be. So this is a great article, especially if you've already had a valve replacement and you're curious or worried about what the future may bring. This would be a good article for you to take a look at. Let's look at the next day. Time to ace your healthcare journey. This is something that we've come up with at Aortic Hope to help you remember how to have successful medical care. Very, very important. If you can remember the letters ACE, hopefully you can remember what it means. So A is to advocate. Speak up for your wants and needs as a patient or for your patient. Speak up for your specialty and the treatment of others with the same disease. So we talk about that a lot. Self-advocacy, very, very important. It's your health, your body, your life. When you see your physicians, you need to speak up for yourself and have control as much as you can over your care. Right? And if you can't, you can have someone else, a health advocate, go with you, and perhaps they can speak up and ask questions. It's very important to be involved. If you don't like what you're hearing, or you're confused, or you don't understand what you're hearing, speak up and say, could you explain that to me again? Could you explain it to me another way? You have to talk about it. Don't just sit there. You have to be an advocate because nobody's perfect. All our physicians and professionals are all human, and they can make errors as well, or they can forget something. They have things going on in their lives, so we have to be aware of what's happening. C is for communicate. Be sure you tell your physician everything and be honest. If they say, have you been feeling, how have you been feeling? Just say, oh, I'm okay. Or have you fainted recently? And maybe you fainted 3 or 4 times. You go, yeah, I fainted. How much? Once or twice. Well, tell them the truth. Okay. Be honest. And doctors, share your information with your patients, which does happen more today, especially with MyChart. Also, educate. Educate yourself on the disease. That's what you're doing here. Read a lot of our articles. We have plenty of these on Aortic Hope. Go to our YouTube TV, AHTV, Aortic Hope TV, and watch many of our different programs on aortic health and aortic disease and learn as much as you can. And it goes to educate, right? Educate yourself. Educate your physicians about your disease. Sometimes you know something that they haven't heard about. You may have read a recent study that they haven't gotten to yet. So that is something you can talk about. And encourage your physicians to educate their colleagues. In fact, you can go on to Aortic Hope, into this website here, and you can ask for other of our merchandise and other of our printed products and take some of our brochures or posters to your doctor's office next time and say, here, would you like to hand these out to your patients? It's really helped me to be a member of Aortic Hope, and I'm sure your other patients with aortic disease might like it as well. And see if you can just put up a little stack of those in your doctor's office. That'll help them encourage and also encourage their colleagues to do things the same. So in summary, typically healthcare is we tell a doctor what's wrong, they tell us what to do, we nod, okay, doc. We hold back our real questions because we're nervous and we don't want to sound like we don't trust them and we're afraid of getting them angry, which if they do, you need a new doctor. We end up back where we started. We've all gone through that. The cycle is not just frustrating, it can be overwhelming, and you deserve better. So advocate, take ownership, keep your records, bring a support person, write down questions before you go, write down the answers, take notes. Your voice matters. Communicate. Find the best way to stay connected with your care team. Use the portal. These things are great. Almost all physicians now have online portals uh, where if you can't get hold of your doctor, if you don't have an appointment for a month or two or something, you can send an email through the portal and you will get an answer. Hear that all the time online. People say, "Well, I don't have an appointment, and I can't speak to my doctor. I call, they won't let me talk to him." No, they won't because they really don't necessarily have time in their day uh, to talk to all the patients that call. But you can use that portal to send them an email, and you will get an answer back, usually in usually in a day or so, if not sooner. But use that portal. They're great tools. Plus, you can also access the records and all sorts of other things on the portal. Okay, ask your questions. Speak up. Symptoms, side effects, things are happening. If your medications aren't working or you don't feel like they are, they don't make you feel good, again, use that portal. Communicate, educate, share your story, tell others, both physically and emotionally. We all know the emotional toll that aortic disease can take on us. It is it's terrible, okay? And we need to acknowledge that and work to lessen that emotional trauma that we can have. So get your family history, go to thinkaorta.us and see all about that. Help your provider see you, not just a scan, right? There we go. Have a partnership. No more silent nodding. No more shrinking yourself in the exam room. Okay? Stand up for yourself, for your health, and for your life. ACE, right? Advocate, communicate, and educate. Saturday, we had the Survivor Series featuring Bonit Sharma. This is a really great story. This is a written story, not a video. So you can come here to the blog, which is right there. This is where these are posted on the blog. And you can read all about it. You can also sign up for a Survivor Series. We're always looking for people to tell their stories. They're very, very wonderful. They help other people see that they're not alone, that other people have the same symptoms, went through the same things after they discovered the disease or had surgery. And it can be inspiring to see how well others are doing now, that there is light at the end of this aortic disease tunnel. So you can sign up for either of these. And if you've done a Survivor Series years ago, you can do the Where Are They Now? Come back and tell us again how your life's going. So Bonit writes about 6 days with a type A start, and everything he went through is kind of long, so I'm not going to read it to you, but you can come here and read his story as well. And I want to say thank you to Bonit Sharma for providing us with his Survivor Series. Lastly, it was Rare Disease Day on Saturday, the 28th of February. This is a day that's sponsored by the Rare Patient Voice, which is a group that we support and work with on a regular basis. So, different diagnosis, they're all about rare diseases. As they say, shared fight, united voices, standing together with the rare disease community today and every day. So, they remind us that every diagnosis is a person, a family, and a story. We stand with them and work with them. So this is another group, another organization that can help you manage your journey through aortic disease. So they also do surveys, they take opinions and so on to improve medical products and services. So they provide some of these to the medical manufacturers and equipment companies and so on. So it's very important to help us help others in the same place. So we do have a click through right here that you can take directly to their to our page with the collaboration for here. I'll do that for you. There we go. We have another page where you can read some more about it and how you may be able to get involved. So I want to say thank you uh, very much, and we did thank our sponsors and those of you that have joined us today. I hope you're having a great week. Uh, every week can be good. It can be great. Take care of yourself. Take care of your life. Enjoy your life that we have. Okay, very, very important. So this is Rob Seltzer with Aortic Hope. And I would like to say goodbye.